Good morning again. It's my distinct pleasure to introduce Mr. Lewis Perkins. Those of you who had seen the previous schedule knew that we had Jane Swain scheduled and experienced an illness. And I can't thank Lewis enough because he has helped KNA in more ways than we can say in terms of providing individuals within his organization who are expert presenters, as well as covering a very interesting and developing topic for us this morning. His presentation is utilization of APRNs in the acute care setting. Mr. Lewis Perkins is the Vice President of Patient Care Services and Chief Nursing Officer for Norton Hospital in Louisville. He received his Associate of Applied Science in Nursing at Whiteville Community College in Virginia, the Bachelor of Science and Master of Science in Nursing from East Tennessee State University, Johnson City, Tennessee, and is currently completing his Doctorate of Nursing Practice, Systems Leadership Program Development at Rush University, Chicago, Illinois. And no, this is not an online program. When I have called, I have learned that he is in Chicago. So one of those things that just really speaks volumes in terms of being a lifelong learner. He has served as Administrative Director for Inpatient Services at Methodist University Hospital, Memphis, Tennessee, and Assistant Administrator, Chief Nursing Officer at Sycamore Shoals Hospital, Elizabethton, Tennessee. He has 7 years experience as a nursing home administrator and patient-centered care coordinator in Johnson City, Tennessee. His professional activities include geriatric, Advanced Practice Nurse Association member, ANA and KNA member, a member of KNCC, Kentucky Organization of Nurse Leaders, and Tennessee Center for Performance Excellence for the Board of Examiners. He collaborated with the Kentucky Board of Nursing to define the scope of APRN practice within Norton Healthcare System, established top-of-line licensure practice for APRNs and LPNs within the Norton system. He is truly an example of lifelong learning, and one of the things that I have gained so much respect for him is that when KBN meetings are held, Lewis attends those meetings and is very much of a listener, and if there are students that are there, encouraging students as well. And I think he's got a quiet but strong leadership capability that we certainly need to recognize. Would you please welcome Lewis Perkins?
I was standing there listening to that and didn't realize I'd been doing so much. We're going to talk a little bit about the advanced practice nurses, but before we get there, we've got to kind of set the setting as to where we're at and why we're doing some of the things that we're doing. So as you look at the objectives, we're going to be talking about or discussing the advanced practice role. We're going to discuss the current state of healthcare, and then we're also going to talk about the impact of leaders and leadership and making sure you take the right approach and use timing to your advantage, as well as having the right catalyst in place or seizing the opportunity when that catalyst appears. A little bit about Norton Hospital. We're licensed for 640 beds. We have an average daily census of about 251 today or this morning. As I checked on the hospital, we were at 302, which means that we're scrambling around finding extra beds because we really staff just around 260 or so. So we've been running over this past summer. Actually, our census is up 13% from last year, which you don't hear much of in the state. We have over 150 APRNs that are employed. And if you take just those that are employed, that 150, that's a whole lot of APRNs to manage at one time. So we have an APRN council. We also have the Allied Health Committee, which used to be called Dependent Allied Health, is being turned into an advanced practice provider council, which I'll be the chair of for some time until we get it established, and then we'll have advanced practice nurses running that themselves. So we'll have a credentialing committee that is a mirror, if you will, of the medical executive committee or in the medical credentialing committee. The 150 APRNs, if you look at them, and then compound that with the private practices, the people that just show up to take care of patients and have privileges, that number jumps to 420 APRNs. So at any given moment in Norton Hospital, as you're walking the hallways, you're going to see 10 to 15 nurse practitioners seeing patients on a daily basis. So the current state of healthcare, does this look familiar? the Republicans and the Democrats fighting about what we should be doing? And there's nothing healthy about it right now, is there? We can make that point even clearer as we look down at the numbers now. If you look at the bottom of the graph, you'll see that $7,000, or actually a little bit more than $7,000, it's around $7,500 in 2009, I believe, is when I pulled this data from, is what we spend per person in the United States on health care. I got some more recent data recently, just yesterday. That number has jumped to $9,500 per person, per month, per person, per year in health care. So you think, okay, well, we're spending a lot of money then, you know, on each person, right? Well, if you look at it in terms of gross domestic product, in this slide it tells us, I think we're at 16%. Actually now we're up to 17% of gross national product. And then if you look at the trend of the other lines there from the other countries, they're coming up too, but look at the gap between us and them. Still spending a whole lot of money on healthcare, and what are we getting for it? So we go to the next slide and you see where we're spending the money. It's in the acute care sector. It's the hospitals, the largest chunk. That should get us to thinking, if somebody's going to target something, they're going to target the hospital, right? And what are we doing in those hospitals that's causing this cost to go up? And what are we getting for it? So hospitals are responding. We've got the Cleveland Clinic, $330 million have to come out. They laid off a lot of nurses. Then if you look at Vanderbilt University, doing the same thing. They've got to get rid of $100 million in fiscal 14 and then $250 million over the next 2 years. IU, I think they laid off 800 folks, and they've got money that's got to come out. I think it's around $1 billion that they're trying to get out. So if you stop and think about this, there's a whole lot that's happening really fast across the nation, and on top of the jobs going away, censuses in some hospitals are going down. I can't explain why they're coming up in our hospital other than that the people 10 years ago or so now focused on hiring private practice physicians and making them part of the system, and didn't balk. When everybody else stopped, they kept going. And I think that's made a little bit of a difference. So if you look at this, the hospitals and hospital systems, healthcare systems are realizing they've got to get cost out, and they've got to get it out fast. They've got to get down to the Medicare, Medicaid spend rates in order to survive. So as you look at this and you think, okay, we're spending all kinds of money, now we're trying to cut some out. Look at what, and we consider the value proposition. What is it that's creating value for us at the current time? So we look at comparisons of value. The U.S. there's seventh last out of this group of 7 countries. These are all countries that are a group of the Organization of Development of Economic Countries, the ODEC. And if you look at this slide, it shows where we rank. And if you look at this, we're 7th out of 7 in several of those, and we're only 4th in effective care and patient-centered care. But quality of care, equity of care, the efficiency of care, we're dead last. Another slide that I didn't put in this one compares us to Japan and cardiovascular disease. We're ranked somewhere, 67th somewhere in the list of nations in heart care. Japan's number 1. We spend $9,500 a year per person on care. Japan spends $3,500. And a lot of people say, well, yeah, Lewis, but look at the lifestyle they lead. They eat healthy. Yeah, they do. That's part of it. How do we get our culture and get our organizations pushing those issues to make the point? We're spending a whole lot of money because of the way we live sometimes. So, Healthy United States. This is from the World Health Organization. We're 37th out of 191 developed countries. We're 72nd in levels of overall health. The key indicators is bad enough that we're at 37, but when you get to overall health, it drops even more. What about Kentucky? We're 44th when you compare us to the rest of the states. We're last in cancer deaths. And near the bottom, we're still at the bottom with smoking, premature birth, hypertension. Cardiovascular disease is the #1 killer in the United States, and we're still right there with it. So we've got a lot of work to do is what this is saying, right? And then we look at the primary care supply of physicians across the nation. 220 or so thousand physicians are going to be needed in the next 10 years. And while that shortage is there, the supply of the NP care is projected to be at an increase by 30%. The supply of the primary care of the PAs is projected to increase by 58%. I saw another slide yesterday from another organization where they're saying that's going to go up to like 70%. That the PA schools have really recruited and started getting those guys going. Assuming that the PAs and NPs were to be able to provide primary care and integrate into the primary care model without the resistance that we're getting from the physicians right now, the need would increase only by 17%. So we do have a solution if we can get everybody across the nation to agree to further integrate primary care with NPs and with PAs. Right now they're putting up the barriers of, we're going to lose. We need physicians doing those things. The physician needs to be the team leader. I'm all about being a team and having the team leader, but maybe there could be a graduated progression of patient care. Maybe there's primary care, then there's another intermediate care, and then there's the critical care. And that the primary care is provided by the PAs and the NPs, and that intermediate care becomes where the physicians are now. They've already established the science enough that, and we've learned enough from it, from our advanced practice, to provide the care that they've been providing. So if we increase the use of the PAs and the NPs, we could alleviate the projected primary care shortage. And if you look at this a little bit further, if we were to do that, the number of physicians practicing in primary care would drop from 77% to 72%. Now, is that a huge loss for them if they stop and really think about it? And when we look at the outcomes, because that's the big thing that physicians complain about when we start this and cause us to have to collaborate or reach an agreement around APRN practice at the state level, was that the outcomes won't be the same, the quality of care won't be the same. But it is. As study after study after study, and it's not advanced practice nurses doing these studies, it's the physicians. And the physicians are doing the studies and they're paying for the studies, but then they get the data back and they want to question it even further. So if it were to happen, we drop their participation by only 5%. And then these are numbers just to support the statistics I was just throwing out there. If you look at it, the need for 2020, if you look at the general practice, it jumps to 187,000, pediatrics to 49, and geriatrics, is my specialty, jumps to 4,300. Another one, this just shows the NP and the PA stats, showing that if we stay where we are, we're having overage unless we can get into primary care and get integrated better. Well, what's that look like in Kentucky? If we look at Kentucky, in 2012, across all 80 counties, we needed 37, or you might as well say 3,800 FTEs. And 61% of those are needed in the rural counties. The county that's struggling the most right now is Boone County. I don't know if I have that up there right now. And they need, yeah, there it is, with a deficit of 16.2 FTEs in Boone County. If only 6%, and then in Kentucky, if only 6% of this number of APRNs were put into practice, Kentucky right now would not have a physician shortage and would not have one in 2020. Only using 6% of the number that we've got up here now. But the resistance, like I said, is the question of quality care and losing maybe turf from the physician's perspective. That brings us to the APRN regulatory model. My doctorate studies landed me in a spot with a regulatory model that I didn't even expect. As I'm going through and developing the role or the program that I envisioned, I took family practice nurse practitioners and put them in an acute care setting. Oh my gosh, the alarms went off everywhere. People were telling me you can't do that. I'm like, yeah, well, I read the regulatory model, I read all this, I'm sure we can. So as we looked at it, so just a brief overview. If you look at the bottom row, that's the actual roles, and I may muddy the water a little bit, but there are only 4 roles. And if you look, I've got, 5 up there? There's only 4. There's the nurse anesthetist, the nurse midwife, the CRNA, and the certified nurse practitioner. Those 4. But the certified nurse practitioner is broken out into primary care and acute care. And that's where we get into the sticky wicket with the consensus model, because there are some people that still think when they read this that a primary care nurse practitioner can't be in an acute care setting. But the model itself in several areas says this is not setting specific. It is patient dependent. It's the care that the patient requires that dictates what kind of person should be providing that care. So that's the roles. Then if you get up a level, that gets you into your specialty areas, or your populations, if you will. It's the family, adult, or actually adult geriatric, and then gender specific, but women's, neonatal, pediatrics, and psych mental health. So that, after you get your degree, then you're specializing in what family or what population focus you would have. And then you can have further certifications. You can get certified in palliative care. You can get certified in oncology if those things are available to be certified in. So that's enough about the regulatory model. I'll talk a little bit more about it when I talk about the nurse hospitals program to help you understand how that was a problem. What this did, though, was cause me to meet new friends. I saw Lahoma just a second ago. She's in the back. I met Lahoma through this, and I met Pam Hagan through this. I actually had to sit down with Pam Hagan and Nathan Goldman, the legal counsel for the state, and I went through the whole nurse hospitals program and the role with them, and they said, yeah, what's the problem? And I said, well, I'm being told that, they said, no, you got this. This isn't a big deal. So it was kind of an odd conversation, because Pam was sitting there thinking, well, when's he going to pop the question of why are we doing this? Or she said, but you understood it. It wasn't a big deal. So anyway, I didn't think I'd have to go down that road. I thought I had it going forward, but we ended up there. So all of this has created what? A perfect storm. All these things are coming together right now and colliding. And some people are sticking their head in the sand and saying, well, the volume's down. We're just going to keep doing the same old thing. And what does that do? It just gives you the definition of insanity. It's doing the same thing over and over and over again and expecting a different result. Well, we had to figure out at Norton Healthcare, we sat down and said, what are we going to do? We can't keep doing the same thing. That's not going to work. We went to an all-RN model in Norton Healthcare. I had, and still do have, 80% BSN RNs in my hospital. But how can I say that when I'm adding LPNs? Because the BSN RN is directing the care for every single one of the patients in the team that they're in. So before we had 70%, or excuse me, 79.5 or somewhere, 79% BSN RNs, and they were providing the direct care. So it was 1 to 5, and now we've gone to teams, which is changing things up a bit. So we got to change things around. And then the other thing I want to talk about is leadership. And Nelson Mandela is one of the people that I think we could all learn a lot from. The man was a rebel in the beginning. I mean, he did some things that he wasn't proud of, but then he learned that it wasn't the violence that was going to make a difference. It was the understanding. And the quotes that I've got up here, I don't have them memorized, but one thing in the lower right-hand corner, it says, it always seems impossible until it's done. And if you think about what we're facing now, it does seem impossible, but we're going to get there. We always do. The one in the upper left-hand corner, I can't read the quote to you, but it talks about leading from behind. It's about a shepherd leading a flock from behind. They guide and direct from behind. They're not out front. So he's a really great role model and if you think about his life and what he went through, he was in prison for 20 years or so because nobody agreed, the African nation didn't agree with his views on apartheid. But he maintained, they were even going to set him free at one point. They said, come on in, sign the paper, we'll set you free. He said, do you agree with us? They wouldn't agree with him, and he said, no, I'll stay. Until you walk and set me free and say that you can at least agree with or understand where I'm coming from with apartheid, then I'll stay where I'm at. And he did. He was finally set free and then became president of the nation. This is a Dilbert comment about transformational leadership. It takes transformational leaders, and I think leading from behind and guiding, directing people, you actually end up transforming those people that you're guiding and directing. And if you look at the Dilbert cartoon here, our differentiation, value-based strategy is transformational change. Okay, he's announced this in a meeting. How is that? Does anybody feel different? How many times do we have a leader who thinks that I can go out and talk about one thing, or I can go out and say one thing, and one of the staff members, my urge to hurl increased a little bit. That's what change feels like as the response from a leader. So we're rolling out a new program and somebody's saying, oh, this is terrible. Well, that's what change feels like. Are we really listening so that we can get to the bottom of things and make things better? Another leadership style. What do you think this one is? Anybody? What leadership style would this represent? The leader's acting like the sharp end of a spear, right? They're the ones out there interjecting themselves and making change. What happens to this leader? Yeah, they get shot pretty quick. Now, there is a time for this, but when you're trying to lead a massive change, the type of change we're leading right now in Northern Healthcare, you can't do it by being out front. You've got to be putting people out in front of you that have the same thoughts and understand where you're trying to get so that they can work it through the system. Another leadership style. This one's kind of networking, right? Connecting things together and getting people to follow in that way. You have to have that occasionally, right? You've got to know who the right connections are so that when you need something done, or you need a certain thing said, or you need a guest speaker to come in and speak about a subject that you know needs to be said, but it would be better heard from them rather than from you. Another one. This one is what? If we're taking the puzzle piece and we're going to pull all those people together, do you think that those people all of a sudden will turn blue, the whole thing will go blue, or the whole thing will go gray? I wonder which one it would be. This is another form of transformational leadership. It's pulling people close together and making sure that they understand what the vision is and that they have the same vision. And if they don't, then how do you get to the same vision? Maybe your vision's off a little bit. They see something a little different. The leader doesn't always have to be right. And then Nelson Mandela again. This is the shepherd quote I was sharing with you a little bit earlier. It says, a leader's like a shepherd. He stays behind the flock, letting the most nimble go out ahead, whereupon the others follow, not realizing all along the way they're being directed from behind. So what is great leadership? There are three things great leadership will do. It achieves organizational effectiveness now. Not 100 years from now, but now. It embeds the goodness of the organization in the practices and procedures, resulting in effectiveness that endures. It doesn't change the personality. It builds it into the processes so that the personality is exhibited because of the processes. And then grows additional leaders at all levels of the organization. If you were to look at the nurse leadership from Norton Healthcare, 60% of it outside of Norton Hospital came from Norton Hospital. We focus on making sure that we're growing leaders. And a recent publication called Turn the Ship Around is a real good example of this. I read this book after I've been at Norton Healthcare for the last 4 years. We just read it, and I'm like, wow, this is what we've been doing. We didn't know what to call it, and neither did, but this guy, David Marquette, captain of a nuclear submarine. How complicated is a nuclear submarine, do you think? Pretty complicated, right? Well, he did something pretty amazing. He stopped commanding and directing. What he did was started getting curious. So the short story of the book, he is an assistant commander, just a step down before commander. He's the next person in line to get a submarine. And he's been studying for this one submarine. I forget the name of the sub, but he's been studying for this one sub, knows it inside and out, can tell you exactly how to run the whole thing. He knows every person's job. He knows every person's role. He can walk up and tell you if they're doing the right job. He can tell them when they're wrong. He knows everything about the sub. Well, he comes up and he thinks he's going to get the sub that he had studied for, and he's handed a whole different submarine called the Santa Fe. The Santa Fe is one of the top classes in the United States Navy. It is also at the bottom of the list for performance. Their safety checks are never on time. They never get out of port on time. They're always making mistakes. and the people don't even care that they're on the ship. So one of the first things he does is create a kind of a motivational type speech, and put some action in place with his commanders, telling them that anybody that is new on the ship, any visiting person, visiting officer, visiting civilian, anybody coming on the ship, would be welcome to the ship by introducing themselves, their role, and the ship's name. Welcome to the Santa Fe, I'm so-and-so, and my role is. He said, how could I even know all the roles? There's no way. It took me 2 years to study for the previous sub. I'm going to this one, I know nothing about it, don't know how it runs. So he had to learn that he had to be curious. He had to ask questions, but he had to be really curious and ask a lot of questions to get the answers that he needed. And over time, what he learned was that he went from a questioning, which, how does this work, how does that work, to being more curious into, well, how does that work and when do you do it? And he gets a lot deeper with his questioning. The more he did that, the more he learned and the more he knew. But then what he learned from that was that the more he learned and the more he knew, the more he trusted the team. And he started telling his team, we need to stop making the decisions. Let the decision happen at the point that the actions are taken. So could you imagine a submarine going into battle, and the commander's sitting in the chair, and he's not given an order to do anything. And the ensign is saying, okay, I intend to drop 300 feet, Captain. And the captain says, so be it. They're telling him what they're about to do, and he just approves it. Or they're saying, tell me what to do. Here's the situation, Captain, tell me what to do. They're lost. Help us out. So this is a whole shift in the way you think about leading someone, and it takes us to a leadership style, which he calls in the book, turning followers into leaders and developing a leader model. Where there is a leader, the one order he kept was to fire any missile or any torpedo. And he said the only reason I kept that order was because somebody was going to lose their life, and I didn't want that on their conscience. That was mine. So stop and think about how we treat other people sometimes. And sometimes we think because we've been in leadership or we've been in nursing for so long, we've got the solution. We've seen these problems play out. We know what the answer is. And I've had nurses come to me and tell me, you know the answer, why don't you just tell me? I said, because then you don't learn anything. Just tell me what you want to do. Tell me what you're thinking. And if you're on track, I'll ask a couple questions. And if not, we'll sit down and problem solve this together so that they learn more as we go. So my directors have essentially almost quit coming to me. They still come to me for some things, but they always say, here's my intention. One of the big surprises a couple of weeks ago, they showed up in my office and said, we're restructuring nursing. I said, you're doing what? They said, we're restructuring nursing. I said, okay, well, let me know what you're doing. And they go through the whole thing. They reduced 3 FTEs, created 2 new positions, and saved us some money. And got some accountability at the A&M level that I didn't even know needed to be done. So they begin to trust and they begin to lead, and it helps everybody. So when you can get to the point where people are telling you, I've been doing, or I just did, or I'm about to, or I intend to, I recommend, I think, tell me what to do, you're starting to make some progress. So innovation. You can't make the big changes without being innovative and understanding what innovation really is. And it's doing things a little bit differently. And if you look at the underlined words, invention, customers, creating value and service, new information or applying information that's always been there, the economical cost, making sure you're looking at cost, sometimes that can drive some innovation. The resources that you have, or lack of resources, can drive innovation. Then the processes and the way that the work flows within a process can drive innovation, because it's not working. You can say, well, that's not working. What do we need to blow the whole thing up? Do we need to add something? Do we take it away? How do we make that better? So innovation, if you want to read more about innovation, I included a web address there that's got some more to talk about or read about innovation. Then we got to talk a little bit about teamwork and war at the mule. Has anybody heard this? It's really an old fable like that. Nobody? Oh gosh, I hope I can remember it then. There's a guy driving down a dirt road in a rural community, right? And he takes his eyes off of the road for just a second to fiddle with the radio. He hits the gravel the wrong way, and he slides into a ditch and puts one wheel up off the ground. So there's no way he can get out of the ditch. Well, there's a farm across the way, And he walks over, crosses the farmer's field, and walks up to the farmer and says, "Hey, I was driving down the road, and my car's in the ditch," and he's pointed, "Can you see it?" And the farmer says, "Yeah, Warwick can take care of that." Well, this is Warwick. Doesn't look like he's much. You can see his ribs back there a little bit. He doesn't look much like he's much. So the farmer's sitting there talking to him and you know, being like a farmer, he's taking his time. This guy's kind of in a hurry, and he's taking his time. He gets as far, Warwick loaded up with the block, gets the hood on him, and they start walking him up the road. They hook Warwick up to the vehicle, get the chains hooked up, get him to step up to where it's tight. And the farmer then pulls out a little whip and snaps it and says, "Pull, Ted." And he snaps it again, "Pull, Fred." He snaps it again, "Pull, Jack." And the guy's standing there looking at him saying, "God, what's going on?" And he cracks the whip and says, "Pull, Warwick." And Warwick takes a few steps forward and pulls the car out. And the guy's real thankful, and he said, "But I've got a question. Why did you say all those other names?" And he said, "Warwick thinks anything's possible as long as he's part of a team." So, you know, you really got to stop and think about how you're pulling your people together to make sure that that team's driving things. And teamwork is the ability to work toward a common vision, the ability to direct individual accomplishments toward organizational objectives. It's the fuel, and this is the part that I really like, it's the fuel that allows common people to obtain uncommon results. And when we really put our heads together, we get innovative and we start trusting one another and really are able to have open dialogue about this is right, this is wrong, and not be offended by it because we're trying to solve a problem. You start to get some uncommon results. So if you look at APRNs, so what do APRNs have to do with this whole thing? Look at this continuum. We've got prevention and early detection. APRNs can do that, right? That's primary care. Family and community services. APRNs can do that. You see them in community health. Primary and specialty care. We've got roles for that. Pharmacies. We've got some APRNs that specialize in pharmaceuticals, but they aren't pharmacists. But so they understand the drugs. That's a connection there, but I don't think we've got somebody that we would say is in that role. Then behavioral health care. We've got APRNs that specialize in behavioral health. We've got emergency care. What is emergency room care? If you stop and look at it, 70% of it's what? Primary care. It's that other 30% where we don't want the APRN taking care of patients. We want the physician in there with those very acute things. And then if you look at hospital care, if you stop and think about hospital care, med-surg, and some of those other areas, you've got chronically ill, stable patients in there. They're not acutely ill in most cases. Maybe the first day they're admitted, maybe the second day they're admitted, but then after that, it drops off to where they're essentially primary care, chronically ill, and you need to stabilize them and get them out. So there's a role in the hospital for primary care. Rehab. We have nurse practitioners that work with rehab patients and work in rehab. And then you've got home care. Nurse practitioners can be in the home care setting. Long-term care. Lots of geriatric nurse practitioners in long-term care. And then end-of-life care, palliative care, and hospice. So APRNs can fit anywhere in that continuum. And then if you look at where the cost is, we've talked about this, it's at the hospital level. You know, right here. That box is really big. If you look at the rest in comparison to the rest, what's going to happen is that box is going to get smashed. It's going to get squished until it's smaller and smaller and smaller, and we can't go any smaller. And it's going to be more acute care than it is primary care. There's still some primary care happening. So how do you go about all this? You have to have a catalyst. And as we talk about the programs that I'm going to show you next, I'll tell you what the catalyst was that allowed us to make a move. Because you can have a solution. If you look at this, the problem may not be new, and the solution may appear that it's a very obvious solution. If you look at, and I modeled this after what I learned in my doctoral program around politics and laws. Stop and think about, one of the first things I read and one of the references an instructor gave me was, and it shocked me that it was out of the Bible, and it was Ecclesiastes, there's nothing new under the sun. All of these problems we've been facing, somebody's faced them before, there's nothing new under the sun. And I'm about to tell you nothing new. I'm about to show you some results of just applying and getting people on board, but there's nothing new to what I've put out there. It really isn't. If you stop and sat down and thought about it a little bit, anybody in this room could do the exact same thing. So there's nothing new under the sun. That really stuck with me too. So you can have a solution, but the solution can be the wrong time, It could be the wrong solution. It could be the wrong people. But you still have the solution there, and you have to find the perfect timing to use that solution. And then you've got to make sure that you are putting in a solution, that you're not treating the symptom of something else. That's another thing that we do in healthcare, that the Six Sigma and the lean processes and the other improvement processes, they talk about it, but I think we kind of gloss over it. If you've identified the wrong problem, the solution's not going to work. You've got to make sure that you've identified the true problem as you begin to problem solve. So, the change needs to be focused on the problem being solved. Identifying the true problem. And there's all kinds of things. Patient throughput probably comes to mind the quickest, that would be easiest, because everybody says, well, patient throughput's a problem in the ED. Is it really? Because the ED can't turn their patients over, they're holding patients longer. Actually, the problem is way on the back end, where we're not discharging patients till after 3 o'clock, and the ED can't get there unloaded because we got beds upstairs that can't be filled. So you've got to truly identify what the true problem is. That's one example. Change, especially innovative changes, must be about the problem resolution, not the person in the process. How many times do we get into a change and, oh my gosh, Lewis is a barrier to this whole thing. We're trying to change and it's him. It needs to be about what the problem is and the data around the problem. And I've got a really good example of this one, which was the catalyst for the APRN intensivist model. There was a physician in our hospital, and I won't give his name, but there's a physician in our hospital whose length of stay has been at the top of the list for the past 4 years. And everybody's been saying, if you will just go meet with that physician, all you got to do is get him to discharge his patient, that'll take care of it. And I kept saying, leave the man alone. The time is not right. Well, we've got to change this. He's spending all this money. Leave the man alone. Go meet with him if you like to. And every time they would meet with him, it got to the point where this was his signal to him. They wouldn't even go talk to him because he wouldn't let them. So the timing has to be right, and you have to focus on the problem. So my opportunity came, well, I'll get to that later, but they were focusing on him instead of the problem. A catalyst is a great way to kickstart the change process. I'll talk about the catalyst as we go through the next slides. The key stakeholders need to agree that there is a problem. How many times have we said, we have a solution that's looking for a problem, and we got key stakeholders out here that don't agree with you, and we try to ram that in and it doesn't work. So and then even if you do have a good solution, you have a real problem, you've identified everything, if all those key stakeholders aren't on board and really agreeing with you, there's going to be all kinds of problems later, especially when somebody comes up with some resistance in some direction. And then that key stakeholder that was wavering flips over to that other side, then you've really got some more issues you have to work through. Doesn't mean you can't get through it, it just means it's going to take you a little bit longer. And this doesn't require a meeting to determine consensus and to proceed either. Doesn't mean you got to call another meeting of the team. No, it's all about the relationship and developing that relationship with the person that has that resistance. They may have a really good reason that you never thought of. It's really drilling down to what is the root of that resistance. And then caution leaders as catalysts. The slide I was talking about, where the sharp end of the spear, there are times where the leader can be a catalyst, but you really got to play that out and understand what's going on. I'm a person, when I get into a new organization, I'll do an assessment of that organization and look at the processes and look at the leadership and look at the outcomes, and then I'll kind of intuitively know, okay, here are the directions I need to go, but while I'm doing that, I'm also looking at who are the key people that I have to have on board before I go into that. When I went into Norton Hospital a few years ago, there was a turnover of nurse leaders as I sat down with them and talked to them about the outcomes of their areas. It made a lot of people uncomfortable. But had I not talked to the CEO and had not talked to the HR folks and talked to several other folks, I probably wouldn't be here because I was being the sharp end of the spear for almost a year before I could say, okay, now I think everybody's getting this, and I started backing away. So the APRN intensivist, the catalyst, we'll go back to the physician. The moment of opportunity came for the solution with this guy when he came to my office one day and said, Lewis, the nursing care in the ICU is not what it needs to be. I said, well, sit down and talk about it. What is it? So he started describing it, and I said, well, is it the nursing care? Are you talking about, everything you're talking about sounds like physician care to me. Because he was talking about people not answering the calls when they were being made, nurses were calling. And then, then he gave us a few nursing examples where nurses weren't following orders, or they were taking the standing orders and using those without communicating with the physician appropriately. So that was the catalyst. And the timing wasn't the right time. He came to me and told me all that. I got started. What it allowed me to do, though, was go to the medical executive committee and talk to the chair of the medical executive committee before the meeting, actually a week before the meeting. And he was the medical director for radiology at the time. So I'm talking to him and I'm telling him, look, I'm getting all these complaints from physicians, because after that one doctor came forward, another one did. And then I said, I'm getting complaints from the physicians, I'm getting complaints from the nurses. We've got a problem in the ICU. And I think a lot of it is dwelling around physician leadership. I'm saying I'm not blaming the physicians, because I'm part of this too. I've got some nursing issues in there. I said, what I would like for you to do is to put this on the agenda coming from you, and I want you to say, Lewis, I need you to work on this. I'm getting physician complaints, I'm getting nursing complaints, that he's getting the complaints, and to ask me to work on it with some physicians. That brought up a whole discussion in the medical executive committee, and other physicians jumped in. And at that point, they all agreed to create a physician-led committee that would look at the care in the ICU. So the problem I was having in the ICU was, at the time, I had a 15-day length of stay. Vent days were out the roof. Mortality rate was around 10. It wasn't looking good in the ICU at that time. And this is all of the ICUs. We had 54 ICU beds. It was all the ICUs lumped together. I wasn't separating one from the other. It was all of them. So in this, my plan didn't work. If you heard me say it was a physician committee, I needed to be involved. So I talked to the person they put in charge of that committee and said, I promise I won't say a word. I'll sit there and just listen. And I won't get involved. I just want to hear what you all have to say, and let's work on this, because I want to fix the things that nursing needs to fix. Well, as I'm sitting in there and I'm listening over the couple of months, I think it was 2 months. By the third meeting, I was asked to chair the meeting, and I hadn't said a word. I was asked by the physicians to chair the meeting because it was getting a little onerous for them. And then, as I started chairing the meeting, other things started happening. They started saying, well, we do want to have an all-intensivist board certified model, but we don't want to close the unit. We do want to have all this, but we can't, there's not enough of us to work 24/7. We don't get paid to work at night like this. There was a whole lot of issues coming up. And a couple of the pulmonology doctors kept saying, well, Lewis, so we're into timing now. We haven't got to approach, but the timing, it's starting to come around for a change. A couple of physicians, I'd heard them talk about advanced practice nurses. Why don't we just use them at night? And one of the arguments back was, well, they're all employed by one of the groups, and we don't want one of the groups seeing all of our patients. So that was a sticking point for them. And a couple of physicians from the pulmonology group kept saying, Lewis, don't you have a solution? I'm like, hey guys, I'm here, I'm just helping you. I'm facilitating, you asked me to chair, I'm chairing. So I pushed it back. And then finally, toward the end of the meeting, one of them got mad at me, and he said, we know you've got a solution. You need to help us. I said, well, if you know what the solution is, what is it? He said, you need to hire some APRNs. I said, is that what you want? So it really, I knew where we were going to end up, but it was getting them on board is what I was trying to do the whole time. They were doing it themselves. They knew the solution. So finally they said, can you hire some APRNs? I said, sure, we can do that, but let's talk about it. What do you want them doing? We went down the whole scope of practice. I presented the consensus model to them. And it got to the point where they were willing to be instructors for these APRNs when they came on, and they wanted the FCCS course in critical care medicine. So we were able to get there and get those folks hired. Actually, it took us, after we agreed to that, it took us almost a year to get them hired. They're actually on board and oriented now. So the approach was to get them engaged and to get them to set up the program the way that they saw that it needed to be, and then I would come back and say, well, okay, if you're going to do that, then I need to do this, and they usually agreed with everything that we had to say. So the process to reach agreement on the model then was to type all of this up into some sort of model that everybody could understand. We went back to the medical executive committee, who approved it without any discussion. They just said, this is what the committee came up with, and they approved it and went on. So we went into the implementation phase. While we're doing all that, this all started in June of 12. The first meeting was actually in May of 12. And the baseline was, average length of stay at that time had dropped, because when I was looking at the data, I was looking at 11 data, we were at 15 days. So we dropped to 11. Our readmission rate was 16%, and our mortality rate was 9. We started implementing this and having all these discussions. Care got a little, everybody's in chaos from it. So our baseline increased our average daily cost up by 4%. Our length of stay went up. Our readmission rate was still dropping. Our mortality rate was still dropping. They were still focused on the care. All right, everything gets put into place for the whole year of 13. Look what starts to happen. We lose 9% in variable direct cost. Cost is going down. Our average length of stay drops another day. Our readmission rate goes up just a little bit, and our mortality rate's down even lower. And then this year, we dropped another 4% in average daily cost. We've got our average length of stay down to 10.2, and it looks like we're going to stay in the 15% range for readmissions, and we're going to stay close to the 7 range for mortality. This is just from organizing the physicians. The APRNs I just said just started. Imagine what's going to happen now when I've got coverage at night by the APRNs, and they're looking at these patients, eyes on the patient within the first hour of admission. Whereas right now, eyes on the patient first 4, maybe 7 hours before a physician sees that patient. They're doing it over the phone. An APRN seeing this patient on admission to an ICU is going to drop these numbers even more. So that's one example. I like that, and I want to be able to know when codes are going in the house. And after the first 4 or 5 months, I noticed there's a lot of codes. I'm not used to being interrupted that much, so something's up. So I got to looking into that, and we had an unexpected code and death rate of about 10.33 per 1,000 discharges. And so that was the catalyst, the thing that got me started and got me thinking, okay, there's a problem here. And I started working on a solution. And I worked on a solution by myself without talking with anybody for quite some time, and then I started pulling people in. The timing. I really couldn't push too hard because I didn't have buy-in yet from the system leadership. This was going to require me changing some FTEs around because it had to be cost. I'd already been told, anything you do, got to be cost neutral. So I'm not used to having a house supervisor with a census of 250 patients, census of 300, 400. I'm used to having a house supervisor. So I looked at the house supervisor roles. We looked at some other leadership roles that were in the building, and I came up with the FTEs and wrote the proposal. It took me 18 months to get the proposal through our system. When I finally got to the chief medical officer at the system level, it took me about 3 months of conversation back and forth with him. He didn't like the name of it, and now I agree with him. I didn't at the time, but people have a point, you gotta listen. I didn't. I've learned that. But the nurse hospitalist program is now getting confused with the hospitalist program, so I've got to fix that. So it took a while to get that done with him. Then after we got that, the approach was, the opportunity presented itself when the A&M started complaining, the assistant nurse managers. The assistant nurse manager is the rapid response leader and code blue leader, but they're also expected to coordinate ICU care, they're expected to coordinate the staffing for the ICUs, they're expected to handle the admissions. There's a whole lot of stuff going on with those guys. And as I dug into the problem, I noticed that they were overburdened, and I also noticed that when the A&M was called, everybody perceived that it was fixed. So there weren't a whole lot of rapid responses called because I called my A&M, and it's all taken care of now. Or so they thought, and we ended up having more codes. So that was about my opportunity to get them in and the timing. So I get them involved, I get the nurse managers involved, we start talking about this program, they're all excited about it, but it takes us a while to get it implemented. So the approach was that we were going to take advanced practice nurses and put them rounding on every single patient in the hospital that is in a transition of care. They either just got admitted, they either just got admitted to the hospital, direct admit, they came up from the ER for admission, or they're coming from PACU for admission, or they're moving from one level of care to another, from the ICU to the floor. We got into that, and it was obvious that was going to be really hard to do for one person in a 24-hour period. We figured out how to triage that a little bit. I won't get into that, that's complicated. And this nurse practitioner would also, as they were rounding on those patients that were in transition of care, also would respond to any rapid or any code blue so that the A&M for the ICU didn't have to respond to that anymore. So we lightened their load a little bit. That was the buy-in for them. Some of them still holding on to it though. That was kind of like a badge of honor for them that they got to do that, the adrenaline rush. They're working through that. So as we got that in place, what the nurse practitioners are doing, if you look at their role, we talk about the consensus model now, because these people are having changes, right? This nurse practitioner is a primary care provider. They aren't writing orders. They aren't dictating the care of that patient. They're evaluating the care that the patient's being delivered. They're looking at the orders, they're looking at what the nurse has done thus far, and they're assessing the patient, and if everything matches, we're good. If something doesn't match, the APRN is talking to that nurse saying, wait a minute, this order's been missed, and I get a different assessment than you do. Do you think we need to talk a little bit? And they'll talk a little bit, and somebody ends up calling the doctor. It's supposed to be, we've got to correct this a little bit because the APRNs kind of want to get ahead and they want to call the doctor. It's supposed to be the APRN calling the doctor, the bedside nurse calling the doctor with that APRN coaching them using SBAR. So that they're listening and saying, here's the situation, here's the background, here's what you think, and you're telling the physician. So this nurse, the APRN, is practicing primary care. They're actually evaluating the care that the nurse is delivering, evaluating the patient, are the two matching or is there a problem, and they're pushing the nurse to do the right thing. In the code blue situation, they're just like any other bedside nurse. They're following the ACL's protocols until the physician arrives, because we've not eliminated the physician from this. The physician has to come because it's an acute change, the patient's dying, and they're going to lead the code. But the APRN hospitalist is there to lead it until somebody shows up that can. So that's the hospitalist program. And implementation, we're fully staffed now. I've got approved for 4.6 FTEs. I had to eliminate 5 to get there. Actually, trade 5 to get there. And we've got a little bit of preliminary data. This is my paper, so I haven't really got all of it together yet. Unexpected deaths and discharges. When we started this in September of 11, as I was looking at it, it was 10.22. In September to August of 13, we dropped to 8.42, and now we're down to 8.26. Now, the caveat with this is I'm fully staffed, but I've got one nurse that we just had a medical diagnosis that's taken her out of practice for a little bit. So I'm fully staffed, but I'm not fully staffed. I'm not there all the time with that support. So, and if you would imagine, the 1 month when I was fully, I didn't put it up here, but the 1 month that we had full support, this rate dropped to 7.3. So what I'm thinking is that once I get everybody there, this is actually going to continue to go down. And what the research or the literature is showing me is that this number, it's possible to get this number down to less than 5. And we're on that path right now. Then if you look at the number of persons coding for the discharges, because the top one is just all codes. Doesn't matter who coded, just all of them. And the bottom one is the number of people in those codes. So, people code more than once when they're really ill. So if you look at this one, we're dropping from 8.45 to 6.5. Now the real impressive thing is the next slide, is the one I'm really impressed with. When you look at the number of rapid responses per 1,000 discharges. Remember, I told you earlier, the A&Ms were doing this before the APRNs took it over. Per 1,000 discharges in September, we had 9 rapid responses per 1,000 discharges. Went up, doubled it the next year, and now we're at 37.36 rapid responses per 1,000 discharges. For every 10% increase we get in rapid responses, we see an equal decrease in the number of unexpected deaths and codes. So all of this comes back to the understanding what the catalyst is, understanding what the resources that you have around you are, and then problem solving from the available resources. They might not be available to you in that building at that time, but what resources are out there in healthcare that could be made available if you negotiate and move things around. So other programs that are being implemented, I won't get into as much depth with these. The APRN perioperative testing, this is a PAT APRN. The opportunity here is that, or the catalyst here was that I think Brownsboro and Suburban, Stevens here, I think Suburban's got one. So the catalyst for me was to get this in place was, hey, they're already doing it, but I want to turn it into a program and see what kind of outcomes we can say to justify this happening. So that was the catalyst. The timing is already moving forward. We got the approval. The person's been hired. The approach is I had a lit search done through the library, sent the keywords to the library, and she got that back to me. And now this APRN we've hired is going through and looking at nurse-led PAT services. And we're going to develop the program and put the metrics in place to demonstrate cost savings to the system, because I think that will be a huge save for us. So, like I said, results are pending. We aren't sure where we're at with this one yet. But some of the outcomes we expect are a decrease in canceled cases, some sort of semblance around lab, decrease in lab usage, then decrease in miscommunication between the practice and surgery, which delays surgeries a lot. And then some increased efficiencies for the anesthesia group so we can get them started on time a little bit better. APRN remote monitoring, this wasn't my idea. This is Tracy Williams' idea, but I included it because she sent me the slide, and then the other thing I'm including it is there was a catalyst that goes back to the cost savings in the system. At Norton Hospital, I've got PIC nurses and wound care nurses that they aren't advanced practice in a sense of advanced degrees, other than they have master's degrees. They are advanced practice in the sense of specialization of the wound care and the PIC. Well, Stephen and other CNOs in our system don't have that. They don't have enough volume to have that luxury of having that service. So remote monitoring by iPad, or sitting at a desk with a video camera and a computer in front of you, you can assess those. So we're doing virtual patient assessments, really what's happening. So if we need a wound assessed at Norton Brownsboro Hospital, they don't have a wound care nurse. They call our remote monitoring center and say, hey, I've got a wound, I need somebody to look at. They put it on the screen, they look at it together, they assess it. They can even teach them how to apply whatever solution it is that needs to be applied at that time. So this one's up and going yesterday, but we had a glitch with it where there's an i3 phone, it's not an iPhone 3, but i3 phone, wasn't recording the right way to transmit the messages, so we had to go back down with it. So we've got some mechanical glitches with this one, but we feel like this is going to give a lot of promise to some of the outlying facilities that we are partnered with. And then we're looking at also, could we do this for other hospitals? If they needed a resource for a PIC or a resource for a wound care, could we not have them remote in and we could help them? So we're hoping that we leverage the APRN resources across the system and maybe even the state at some point, increase nurse job satisfaction because they're going to have additional support, and then decrease some adverse events because they're reaching out and getting some real-time knowledge, actually hands-on knowledge. And then chronic disease management. The catalyst here is readmissions. You look at this, we're getting penalized for any readmission coming back to the hospital within 7 days or within 30 days. We had a role within the hospital called the chronic disease educator. And the whole educator role in nursing has always had me sometimes for it and sometimes against it. And I never know where to be with the education role because now it's becoming more and more that you've got to have hands-on and you've got to have results. And it's hard when you've got somebody totally dedicated to an education role, it's hard to see the results of what's happening. So this nurse, her primary role is education, but the results of her education should result in decreased readmissions. And what we've done here is another lit search, the advanced practice nurse in chronic disease management, and how do we get that done without putting them in a clinic? Can they be mobile? So what we're looking at is our data on this group is there's 109 patients that are regularly readmitted to Norton Hospital that have over 60% of the readmission encounters. So this nurse is getting to know those folks on a personal level and may even go out to see them just to check on them, not to provide home nursing care, but to ask a question. Have you seen the doctor? What's your house look like? You know, da-da-da-da-da. And then if they need help, they're going to call the physician and be on their way. Or we're going to do it from a remote monitoring center. We can call the patient, check on the patient that way. So this person is really working to get a relationship with these patients that tend to be really familiar with us and figure out ways that we can keep them from coming into the hospital, but getting the care that they truly feel that they need, and a lot of times do need. Behavioral health APRN. I want to have a behavioral health APRN that rounds in our hospital. It's not tied to a service, but how many times do we have nurses that are dealing with a delirium and don't understand what is causing that delirium, or physicians dealing with the delirium in an elderly patient that doesn't understand it? Or we get somebody that's just really difficult to deal with, or, you know, so that the nurses have somebody that can manage those issues around somebody that is confused or disoriented or has a mental health condition that just needs to be addressed on the floors that's not safe to go to a behavioral health unit somewhere. So we're still waiting on the catalyst or the opportunity to insert that into a program. And that was the reference for those primary care projections that I gave you earlier. And here's my contact information. And that's a cartoon war. Any questions?
Do we have any questions? If not,